Thank you all for joining us today. My name is Dr. Kate Curley, and I am the Director of Chronic Disease Prevention and Programs from the AMA's Improving Health Outcomes Group. Now, I'm a family physician. I'll be your moderator for today's session. Before we dive into the discussion, I want to quickly share that if you do have questions today, please add those into our chat. We're going to do our best to get to as many audience questions as possible later during the Q&A portion of the broadcast. We are really excited to be talking about bridging the gap between hypertension and obesity strategies, where we're going to be discussing the Obesity Medicine Association's clinical practice statement on hypertension and obesity. So I know we all know that hypertension and obesity are two very prevalent health conditions that many people experience, and oftentimes these conditions coexist. So today we have joining us Dr. Harold Bays. He is the Chief Science Officer of the Obesity Medicine Association, and he is the Editor-in-Chief for Obesity Pillars, which is the journal of the Obesity Medicine Association. Dr. Bays is board certified in endocrinology and internal medicine. He is a diplomat of the American Board of Obesity Medicine and the American Board of Clinical Lipidology. He is a medical director and president of the Louisville Metabolic and Atherosclerosis Research Center and associate clinical professor at the University of Louisville School of Medicine. And he has served as an investigator for over 600 phase 1 through 4 clinical trials regarding treatments for obesity, dyslipidemias, diabetes, hypertension, and other cardiometabolic and hormonal disorders. So again, today, we are going to be talking about the intersection of hypertension and obesity, the standards of care, and really different ways that physicians and providers and care teams can really address this issue. So we're going to dive into our conversation momentarily here. First, I do just want to share that Dr. Bays has some disclosures. And Harold, let's get into this conversation. Let's get into our first question. So if we go to that next slide, thank you. What are the challenges and really the obstacles in achieving standards of care for management of hypertension among patients who have obesity? And if you can start to touch a little bit on how we overcome those challenges.
Well, first of all, thank you so much, Kate, for having me here in the American Medical Association. We always are really big, I think, on these programs of talking about disclosures, and usually that's really focused on industry disclosures and such. But I got to say, I think there's another disclosure people should know about me is that, yes, I think a lot of people know me with regard to anti-obesity drug development, medication drug development, and certainly lipids and diabetes and such. And yes, we have conducted a number of anti-hypertension, clinical trials and such, but not a lot of that going on right now. We have some, but not a lot. And sometimes it's just the nature of things, not making value judgments, but sometimes it's that excitement about new research that drives presentations at scientific conferences or what gets published in journals and such. And I got to tell you, it's a disclosure that I need to make. I think many times one of the biggest challenges or obstacles in achieving the standards of care for patients with hypertension is recognizing the importance of hypertension. It's just a thing with me. I just don't think hypertension's talked about enough. That's the reason I'm so honored and happy to be on this program, because we just don't hear a lot of people talking about hypertension, not like we do with the obesity or with the diabetes or with the lipids and such. So it's great to have these types of conversations. And the other thing I would say is, you had correctly mentioned right at the beginning, there's this intersection between obesity and hypertension. And I would say that the most common cause of hypertension, and I use that word specifically, cause of hypertension, is the increase in body fat. And we'll talk about why that is later on. But the fact is, it's not like, I hate this term, comorbidities, as if you had this and you had this and they just happen to coexist. No, I think for many patients, there's a direct causality between the increase in body fat, development of the high blood pressure, and up until recent years, we've had some effect of anti-obesity medications. We've had some evidence of improvement in body weight with nutrition, physical activities, and such, but it isn't anything like where we are now. And so I think you are hearing a lot more people now focused on, okay, what are these, particularly these medications, these highly effective anti-obesity medications, what do they do, not just with regard to the weight of patients, but the health of patients? That was the focus of our clinical practice statement. And I think that's a real focus that clinicians are going to encounter going forward, because again, it's not just the weight of the patient, although that's important. It's what do these newer medications, these newer therapies do when it comes to things like diabetes, things like lipids, things like arthritis and sleep apnea. And with regard to this discussion, what are the effects of these anti-obesity medications on hypertension?
Absolutely. I think you're really touching on the idea that we're really thinking about whole cardiometabolic health now. And when we think about treatment for obesity, we're getting past weight loss treatment, right? We're thinking about whole person treatment. If we go on to the next slide, can you talk a little bit about how you're thinking about obesity these days, how clinicians should be thinking about obesity these days?
Well, look, I know we live in an age of political correctness, and I get that. And I understand that a lot of times it seems like we're very careful about our wording. I think we want to be sensitive to a lot of issues and such. Sometimes you can make the argument it goes to extremes and such. But when we say obesity is a disease, all right, when we say obesity disease, that's not political correctness, right? That's basic medical science. And what do I mean by that? Well, as you can see from this slide here, obesity fits every reasonable definition of a disease. Okay, you diagnose it, right? Okay, there are anatomical abnormalities. There are dysfunctions of body organs, particularly the adipose tissue and such. And these abnormalities and these dysfunctions contribute to increased morbidity, increased mortality. It has a cause, right? Diseases have a cause. Obesity has a cause. There are genetic components and inflammation, certain sort of toxins and such, nutritional abnormalities, unfavorable environment and behavioral issues and such. That's very common among diseases, with obesity not being an exception. And then there's the treatment and who treats it. You say you're family clinician, I'm an endocrinologist, right? So all of us, and it isn't just us, I think you would agree that when managing patients with obesity, it's a team approach, right? It's a team. It's not just physicians. I know this is the American Medical Association, but it's not just physicians. We have nurse practitioners, physician team, right? It's a team approach. And and you have dietitians, and you have exercise physiologists, and you have behavioral modification. You got all of these people all coming, bariatric surgeons. Let's not forget those folks, okay? So entire team of people to get together, treat the disease. And again, it's a multifactorial disease that's managed by a multidisciplinary team. That's the very definition of a disease.
We go on to the next couple of slides. I think you really touched on exactly this, right? This is a disease. I think many physicians would agree with you now, but then do we really sort of walk that walk? Maybe we're talking that talk, but do we walk that walk? Is there anything you want to touch on in these next couple of slides to add to that?
Yes. I mean, here's the big, so I think most people have kind of gravitated in that way, whether they want to go in that way or not. Okay. I think they feel compelled to agree that obesity is a disease, many folks. But still, I think there's this intrinsic bias about obesity being a disease that we, standards that we would not apply to any other chronic disease. So, Kate, I'll give you an example. Let's say you have a patient with the diabetes or the hypertension and the dyslipidemia. And you go to your patient and say, okay, I'm going to put you on an anti-diabetes drug, or I'm going to put you on an antihypertensive drug, or I'm going to put you on a statin for your elevated cholesterol. And the objective is, Once we put you on the drug and your blood sugar gets where we want it, and your blood pressure gets to where we want it, and your lipids get to where we want it, we're going to stop the drug. We're going to stop your diabetes drug, and we're going to stop your antihypertensive. We're going to stop your lipid drug. My guess is you would never say that. Right now, don't get me wrong, maybe 5% of times patients totally change their nutritional intervention, totally change their physical activity, totally change their behavior. And yes, for some patients, they are able to stop their diabetes drug and hypertension or dyslipidemia, but that is not common. It's not the expectation. And yet we get asked all the time, okay, how long do I have to stay on my anti-obesity medication, right? So yes, I think that there is an understanding that obesity meets the definition of disease, but I'll ask you, do you think that with regard to the clinical management, that clinicians always manage obesity with the same sort of perspective as they would diabetes, hypertension, or dyslipidemia?
No, I really think we don't. And I think that is that sort of mental paradigm shift that we would like to see more physicians making at this point, right?
Absolutely.
Absolutely. Let's move on to the next slide. What do we have here? Do you want to talk a little bit more about how obesity really contributes to metabolic disease and cardiovascular risk?
Yes, because I think this is very important. So let's say a clinician says, okay, everybody seems to think obesity is a disease. I have some misgivings about that, but okay, I'll go along. Well, okay, if you're going to buy in, then I think if a patient asks you, well, how did I get my diabetes or my hypertension or lipids, and what is that relationship to the increase in body fat? Well, I think it is perfectly appropriate for the patient to have an expectation that a clinician, and by clinician I mean physician or physician assistant, a nurse practitioner, whatever, be able to explain in a simple way why it is that these complications occurred. Because again, I am opposed to this notion that they're just comorbidities. They just happen to kind of come together in the same patient. I think for many patients, there's a direct causality. And what are those causalities? It's whenever your fat cells enlarge or whenever your adipose tissue expands, then your adipose tissue or your adipocytes become dysfunctional. And just like we have, cardiomyopathy and nephropathy and enteropathy and all these other opathies of all these other body organs, we also have adiposopathy that occurs with the adipocyte hypertrophy and adipose tissue accumulation. And then that results in hypoxia, that results in intraorganelle stress, that results in immunopathies and endocrinopathies and lipotoxicity, which contributes to the diabetes and the hypertension and the dyslipidemia. So again, not saying it's true for everyone, okay? Hard to quantify the degree that it contributes to these complications for everyone, but there is no doubt that obesity is a disease, and as a disease, it has adverse consequences that result in ill health to our patients.
Absolutely. I mean, what more do we need to know to be really convinced that obesity is a disease? Yeah. I think with our next slide, we touch a little bit on the concept of sort of fat mass disease versus adipopathy. I can't say it. You have to help me, Harold. Okay. Is there anything else you want to lay out with those two topics?
Yeah, I mean, just basically, if you want to categorize here, categorize is you have the dysfunction of the adipocytes and the adipose tissue, and that results in deranged endocrine immune responses. And that's when you get, so the adiposeopathy is you end up with the abnormalities in glucose and blood pressure and dyslipidemia and other metabolic disease. But then I think we all recognize that in addition to that, which is bad enough, we also have the abnormalities of physical, biomechanical physical forces and such, where you have stress and weight-bearing joints, osteoarthritis, tissue compression, sleep apnea, these types of things. So that's sort of a categorization that you can find in many of our patients with obesity.
I really appreciate that categorization too. It really helps me organize my thinking about sort of pathophysiology and the relationships between diseases when we think about obesity. So in reviewing material, getting ready for this talk, I particularly like this slide. It really helps me think about
Now,
how to categorize my thinking. Yeah.
I don't want to kind of throw anybody a curveball. This is intended for everybody out there, tended to be simplistic. I understand there is crossover. So, for example, thrombosis. You could say that thrombosis has an element of the causality due to physical forces like compression, but also there's all sorts of immunopathies and endocrinopathies that can treat thrombosis. Some people feel the same way about arthritis and such. But to your point, I think for most clinicians, being able to separate these two things out, I think there is clinical value to doing that.
Yeah, I agree. I like this. So if we go on to the next slide, I have another kind of high level question for you. So how could you summarize the points, sort of the key differences and the similarities between patients with hypertension who have obesity versus patients with hypertension who don't have obesity?
Right. So I think one of the biggest differences might be the diagnosis. So let's say, for example, you have a 20-year-old body mass index of 20 kilogram per meter squared, not underweight, but certainly not overweight or whatever. And they have big time hypertension, right? Big time hypertension. I think most people would really want to aggressively figure out why. So we're talking about more about this later on, probably going to give you a signal that there's something going on that you really need to focus in upon. On the other hand, if you have an older person that kind of gradually, as their weight has increased, their blood pressure has increased, we don't do, catecholamine testing for pheochromocytoma on every person who has mild hypertension, right? We don't do that. We do look at the clinical presentation and such. So the first difference would be the degree by which you're going to explore potential secondary causes. But then as far as treatment, you and I are probably going to have a conversation about this. Look, there's some antihypertensive medications that can result in edema. And given that peripheral edema is a common complication of the patients with the overweight and the obesity, and given that we do still measure body weight, and in many of our patients with the overweight and the obesity, I think it's probably best to avoid drugs where you have a reasonable sense that there's going to be an increase in edema. So if you have a choice between one drug and another drug, one contributes to edema, the other does not, even though it's not really affecting fat mass, I think just to avoid that edema, which is uncomfortable for patients, okay? And also it's sort of discouraging if the patient sees that their weight is increasing, even if it's water weight. If you have the option between a drug that contributes to edema and one that does not, then maybe choosing the antihypertensive less likely cause edema is going to be your treatment of choice.
Yeah, completely agree. If we go on to the next slide, I think we've touched a little bit on this concept of sort of non-obesity related causes of metabolic disease. We've talked a bit about type 2 diabetes, high blood pressure, dyslipidemia. I'm really interested in the next slide that you gave us, though. Maybe we can spend a little bit of time on this. You have this great, I don't know how to describe it, this sort of spoke pattern diagram, right? With sort of these obesity related sort of hypertension, sort of talking about how obesity contributes to high blood pressure. Can you talk about that a little bit more?
Right. And so I think a lot of that goes back to what I was saying before is, if you've really bought in to obesity being a disease, then you need to become an expert as to how it is that the obesity contributes to things like hypertension. Now, respective to the previous slide there, the reason I included that is to make the point that there are many cases of diabetes, hypertension, dyslipidemia that have nothing to do with body weight. Don't have anything to do with body weight.
Right.
And I think we all should keep that in mind, because as much as I'm an advocate for the fact that obesity is a major driver for most cases of hypertension, most cases of diabetes, type 2 diabetes mellitus, probably most cases of things like triglyceride elevation and such, it's not the only cause. And so what I would really, really like to caution clinicians is, just because a person has overweight and obesity, don't assume that every ailment that affects these folks, okay, that it's due to the overweight and obesity. I mean, you want to find out a way to have it where patients with overweight and obesity never come see you again, like don't get adequate care. Best way to do that, best way to discourage people from getting adequate care, is every time they come in, just blame any complaint that they have, any kind of medical issue that arises. Just say, well, if you just lose weight. That is not good medicine, and it is highly counterproductive. So even though I understand overweight, obesity, major contributor to these metabolic diseases, it's not the only contributor. You need to be on it. You need to keep your mind open to look for potential secondary causes rather than just assume that it's due to the obesity. Now, if it is due to the obesity, how is it due to the obesity? Well, unhealthful nutrition, and that can be even above and beyond just increase in caloric balance. So if you're, for example, consuming a lot of processed food, ultra processed foods, it is likely that a lot of those ultra processed foods have high saturated fats, a lot of sodium, right? So it isn't just the caloric content, but it's the qualitative content that contribute to
nutritional quality, right?
Yes. And sometimes just telling people, look, this stuff really matters. Like the other day, I found out some of my favorite tortilla chips. I'm not going to say the brand because you don't want to look like you're selling stuff, but they have a low salt. They have a low salt option with them. I am fine with that. Okay. So anyway, people don't want to listen to what I eat, but then physical inactivity, right? That can contribute to increase in blood pressure. Insulin resistance. I think most people understand about that interconnection between insulin resistance and vascular stiffness and such, right? Endothelial function. I think everybody's heard those types of terms. What about sympathetic nervous system? An increase in body fat increases that sympathetic nervous system, squeezes the vessels or at least keeps them from dilating. Blood pressure goes up. Renal abnormalities, the kidney. I mean, one thing that we're really hearing more and more and more about is this interconnectivity between an increase in body fat and kidney disease. Yeah. So stay tuned. Vascular abnormalities, heart abnormalities. We talked about hyperinsulinemia, right? And then there's things like sleep apnea can contribute to an increase in blood pressure, as well as psychosocial stress. We didn't even touch upon genetics. And then finally, socioeconomic status and such. All of these things that are encompassed within the context of a patient with overweight and obesity, they all have the potential of contributing to the hypertension.
So much interconnectivity between all of these components, I think. By the way, you said something a couple minutes ago that I just want to really emphasize. I like how you framed, the idea of constantly harping on weight loss, as a physician, constantly harping on weight loss. You didn't just say it's not effective, you said it's counterproductive. And I think that's just a really important point to emphasize. Let's talk more about treatment. Let's kind of shift our focus to treatment a little bit. So again, you heard a minute ago, I like categories for organizing my thinking. So I really like where we're going here. Can you tell us a little bit about what the 4 pillars of obesity treatment are?
Right. So the Obesity Medicine Association, we've got these 4 pillars. So there's nutritional therapy, then there's physical activity, behavior modification, then medical intervention. Medical intervention would be medicines, but also surgical, like surgical interventions, right? So it's just some sort of things that we're doing as physicians, as clinicians, try to intervene. So nutritional therapy, pretty straightforward. We're talking limiting that saturated fat, limiting the sodium, trying to, really limit ultra processed foods and such. And yes, at least as your initial treatment is a reduced caloric content of the foods you eat. Now, one thing that people here might find of interest is where we're gravitating now. And we'll see if we end up being there. But where we're gravitating is that the emphasis of nutrition in people treated with these, in people treated with these GLP-1 receptor agonists, we're looking towards the quality of the diet. Let me get a drink here.
Yeah, get a drink. Get a drink.
Okay, we're looking for the quality. And one of the specific quality aspects would be protein.
Yes.
Enhancing the protein so we can preserve muscle mass.
Yeah, I have noticed sort of in the popular media, just in discussions with friends, how much attention people are placing these days on the importance of protein. But it seems like an opportunity really to shift some focus away from sort of constant calorie counting, sort of looking at energy, right? Which is what I think many of us have focused on for a long time, and thinking about nutrition a little bit more holistically, not just that energy balance, but also other nutritional value that we sometimes don't think about. Are you able to touch a little bit, still on this slide, can you touch on behavior modification a little bit? Why that's a separate pillar maybe from that nutrition and physical activity, those couple of pillars?
Well, sure. Just to nail down the nutrition thing though is, once, because you said it spot on, is that in patients treated with the highly effective anti-obesity medications, right, the new GLP-1 based therapies, the emphasis is not so much on caloric restriction from a nutritional standpoint. I think the thinking is the GLP-1 receptor agonist going to do a lot of that. And what you don't want is when you have the weight reduction, right now, if you don't engage in routine physical activity or enhance your protein intake, 20 to 50% of the weight reduction is muscle. It's muscle.
Mm-hmm.
Don't want that. So that's what I'm saying. It's the nutrition. We're gravitating towards a different paradigm where we're looking at the healthfulness of the nutritional intervention and not so much focused upon hypocaloric intake, even though that's going to happen because of the use of GLP-1 receptor agonists. All right, so the physical activity, behavior modification, and I think most people are familiar with the non-exercise thermogenesis, right? Non-exercise activity of thermogenesis, the NEAT. And what we're talking about here is what you really want to do and advise your patient is to be inefficient. Now, that's a concept that I'm not sure everybody understands, but be inefficient. You don't want your patients to be efficient. You don't want to say, when it comes to nutrition, sure, just go to the vending machine, get something that's easy and that's caloric dense, ultra processed, but you can pay for it, eat it all in like 30 seconds. Don't want to do that. You want to be inefficient. You want to make it so people, cook their own meals and shop for their own foods and make sure it's healthful and these types of things. Same thing with physical activity. You don't want to park the nearest to the building. You want to park the furthest from the building.
You know what my example of physical activity inefficiency is? When I need stuff from the basement, I try to do it all in one trip, right? I'm always I want to take everything and I have to pause and I have to think, no, break it up, take the 2 trips to the basement instead of the 1 trip. Get that extra round of stairs in there, right?
And then you could throw in things like elevators,
throw
in things like escalators, or how about this, on a treadmill? I'm as guilty as anybody. I don't intend to people think I'm levitating above anybody here because I'm as guilty of these things as anybody else. But I did not know that, so I was walking a treadmill, I got the incline, got it up to 10, I'm killing it, man. But I found I was holding on to the bars, like holding on to things. Why not? It was easier. It was more efficient. I was able to get the incline up. And then I read that you're losing 30% of the benefit by holding on to the bars. That's ridiculous. No. So I let go of the bars. Oh no. Major difference, right? Being inefficient was a major difference. So for the same length of time I'm on the treadmill, just by simply not holding on to the handle. Do you see where I'm going with this? Absolutely, there are all kinds of behavioral modifications you can do where if you're focused, just things like eat foods that are inefficiently absorbed from the gastrointestinal system, not efficiently absorbed. Right. See, so just be, 2 words, be inefficient.
That might be the most important take home from this conversation, to be honest. Be inefficient. It goes against my nature, but it's wonderful advice in this case.
I got Kate, then I got to throw this in here. How many times have you seen a patient? Maybe they're a physician. Maybe they're an expert in computer science and write code or whatever. Just extraordinarily driven. Just an amazing business person, whatever. Work all the time. And yet the one thing they cannot overcome is the obesity. For someone to suggest that these folks that we see, and they're not uncommon, are somehow, lazy or unmotivated. You're like, how could you possibly even think that? This person's working 60 hours a week, right? Is committed their entire life to these things. What is it about them where the one thing they can't seem to get over is the obesity, right? How about this? Maybe it's the exact same mindset that caused them to be successful is because they were extraordinarily efficient. They were able to efficiently get work done, get their operations of their business in the most efficient way possible. Just efficiency is what is it that contributed to all the successes they've had. But that same sort of mindset of efficiency, while great for business or academic achievement or success in all kinds of life endeavors, that same efficiency mindset is a detriment, it's a block, it's an impediment towards effective weight reduction. I think letting patients know that, say, look, the things that have contributed to your success, that mindset, that's what your challenge is now. You've got to say, when it comes to your health, got to be inefficient.
I love this framing. I actually have never heard anyone frame it that exact way before. I think that's a great way to think about this. And it really reflects both how we behave as individuals these days, but also how we've set up our environments as well, right? To be as efficient as possible. And
exactly. And you can even, for the molecular biologists out there, what about your mitochondria, right? There are certain medications you can take or certain therapeutics you can take that causes your mitochondria to be less efficient. And what happens? You burn off heat. See what I mean? So it goes from the molecular basis, the behavioral basis, to the macro basis across all levels of life and living and what we are as human beings. This whole efficiency versus inefficiency affects us in every way.
Yeah. Well, thank you for outlining this in this way for us. Let's keep going down this discussion on treatment. So what impact do treatment options have on patients with hypertension and obesity? You got it, I think, a little bit of this before, of course, but we can kind of go further here, I think.
The first thing to know is I think it's highly variable because, again, it depends upon the cause. And if we accept the fact that, yes, obesity may be the predominant cause of most cases of hypertension, but not the only cause, then I think that helps us understand why it is that some people respond so well to nutritional intervention and physical activity, and then other people don't. So that's widely variable. And look, there are even situations where if you implement a healthful nutritional plan and routine physical activity, even if there is no weight reduction, sometimes that blood pressure can come down, right? So I think we just need to have a recognition that implementing these types of what people call lifestyle, but I just say nutritional intervention physical activity, these types of things. Medications, clearly, there's two aspects. There are the medications that actually worsen the overweight and the obesity. So that option should be out. Like, you ought to go through the medication list and try to avoid the medications that are obesogenic. But then, yes, we have multiple medications out there, not all, but multiple medications that, especially when associated with weight reduction, that there is a substantial reduction in blood pressure. Not all medications, but many of them, reduction in blood pressure.
Right. And I think we have a couple slides maybe to illustrate some of these points. If we go to the next one, actually, this first, I think you had mentioned DASH. We get asked all the time, what's the best quote unquote diet to eat, right? So how do you respond to a question like that?
Yeah, look, I understand Mediterranean diet, got a lot of evidence, love it, recommend it and everything. But boy, it's tough to find a nutritional, dietary plan that's any better than the DASH diet. I mean, I know it's been around for decades and whatever, but it's really, really good. So for me, and I must say with hypertension, I think DASH is still the gold standard. And then if just for cardiovascular disease prevention and healthfulness of the diet, neck and neck, Mediterranean diet and DASH, but it just doesn't get much better in my judgment than the DASH diet. Well, I'll ask you, you work with the AMA on all these types of things. What's your position and the AMA's position on the DASH diet?
I don't believe the AMA has a formal position necessarily. However, I completely agree with your assessment of the evidence. I mean, certainly Mediterranean diet, we see many, many good things with that. It is very hard to compete with the track record of the DASH eating plan, and we see so many benefits from that. And in fact, I think that's also why the dietary guidelines for Americans, which are not designed for disease treatment, right? Those are designed more for health promotion and disease prevention. Nevertheless, those guidelines very much align to the DASH diet, right? So we just have such an incredible track record for DASH, particularly as it relates to high blood pressure, but a number of factors as well. Like you've really outlined here in this slide, we see that weight reduction. We also see that blood pressure reduction with DASH. So it's a great choice.
And this goes back to what I was saying before. How many times do you get emails per day? I mean, not emails with like some news organization coming up with some sort of nutritional plan or whatever, you can just, I don't want to say any specific ones, but, this plan and this plan and this diet and this diet and this diet. When is the last time you saw anything about the DASH diet? Like hardly ever. Nobody,
I know.
Again, nobody, we want to talk about all these other things because everybody was looking for an easy way out. This is proven. It's effective and nobody wants to talk about it.
I know. I'm glad you raised it because it's important not to lose track of, and it's a common sense, effective eating plan, I think. Yeah. If we go to the next slide, anything that you want to touch on specifically with physical activity as we think about obesity treatment and the impact it can have on hypertension?
Yeah, I think that there's a need to be, look, I think people should be aggressive about nutrition, physical activity and such. But I think if you have a patient who's had physical inactivity for some time and have multiple cardiovascular disease risk factors, I think, starting, with modest increases in physical activity and then gradually increasing and if need be, getting some sort of baseline cardiac testing if that's felt to be appropriate or whatever. Just keep that in mind because a lot of times patients, when they finally make the decision they're going to really address their obesity, they want it fixed tomorrow, right, or today, and then they go to the gym and they just do way too much, and not only is that going to be discouraging because they're not going to be able to keep that up, but it could be unhelpful. It could be from an orthopedic standpoint, but certainly from a cardiovascular disease standpoint. I think just making helpful recommendations and even using the exercise prescription, like where you write out specifically what your expectations are, monitor it, and then escalate that as it seems appropriate.
I think those are great points. What about bariatric surgery? Where does that fit into the treatment picture here?
Yeah,
If
I
we
mean,
go to
look,
that next slide.
yeah, I mean, it improves blood pressure, and that's absolutely true, but it reduces the risk of cardiovascular disease and reduces the risk of cancer. So, it causes, a substantial number of folks to have their type 2 diabetes mellitus go into remission. So, look, bariatric surgery is just it's a highly efficacious, approach. You just need to just ensure that whoever's performing the surgery, has the proper qualifications, proper records, and these types of things. And then also being absolutely sure that after the surgery, there's that appropriate follow-up. Where I've seen the biggest problems with bariatric surgery is not through fault of the clinician, although maybe sometimes that happens, but sometimes the patients just don't go back for follow-up. And as an endocrinologist, I can tell you, we see, I've seen horrible cases of osteopenia, osteoarthritis, osteoporosis because didn't take the calcium supplements, or maybe they have anemia because they didn't take the iron supplements. There's a lot of work that goes into prior to having the surgery, but then there's a whole lot of work that goes in for the longitudinal care, and people need to understand that it's a lifelong commitment. It's not just, I'm going to get my surgery and I'm good to go. It doesn't work like that.
Yeah, you hear it talked about as an easy solution to obesity. And I certainly have never encountered a surgery that I would characterize as easy. And certainly this requires a lot of intense planning and preparation and very good, as you said, longitudinal care over time, but can be so, so effective for many of our patients. I think if we go to the next slide, you were touching on this a little bit, really kind of acknowledging that several of the anti-obesity medications that we are using these days can actually have apparently some impact on blood pressure, right?
Yes, and I think so I know when people look at this, they go, well, that ain't a lot. It's not particularly impressive, thing. What I would caution people, and this is what I tried to say before, when anytime there's reporting of like large data sets, there's always the potential that it's going to diminish the effectiveness that you would often see in your patients, because again, this is all comers. That's just the way, a mean value is exactly what it means. It's the average, right? It's the average effect. I think you would agree that if you've got patients, for example, that are on, that have substantial weight reduction, whether it be through nutritional intervention, physical activity, anti-obesity medications and such, depending on which ones it is, you're certainly going to get, in many patients, you're certainly going to get greater than 5 millimeters of mercury reduction, greater than 6 millimeters mercury reduction. That's what's seen in the clinical trials. It's just when you average everybody all together, those other cases where people do, much, much better, that kind of gets blunted when you report mean values.
Yeah, I think we can also acknowledge when we think about sort of population mean average changes in blood pressure, I mean, a change of 4 millimeters of mercury systolic is very clinically meaningful. There are clear health benefits for the population. So these types of numbers, to me, they mean a lot in the blood pressure world for sure. Well, I think sort of continuing down this discussion about medications a little bit more, and you've touched on this a little bit already, but I think I want to revisit this topic. Yeah. Are there specific antihypertensive medications that are more effective or more preferable for patients with obesity? I think you have a good slide about that next.
Yes. There are certain antihypertensive medications associated with increase in body weight. I think these things are variable. I think people have variable experiences with these things. So certain beta blockers can potentially increase body weight. Certain calcium channel blockers, again, increase body weight, but not necessarily on the basis of increasing body fat. And we talked about that. How nifedipine and amlodipine often associated with edema and these types of things. And there are other options of calcium channel blockers. It doesn't have to be those two. I mean, I think diltiazem, verapamil are pretty good drugs. And so maybe in other situations, some of these other calcium channel blockers are fine. But if you have a patient with, significant obesity already, if they have edema and such, might want to think about different choices.
Yeah, we talked about this too when we chatted last time. I love amlodipine.
I know.
It's one of my favorite medications
I was scared to say anything.
use. Yeah, for hypertension, but I mean, it's a really important point to think about that lower extremity edema when using amlodipine. If we go on to the next slide, what do we have coming up? I think really continuing to kind of go down this treatment discussion, thinking sort of broader strategies here. So what are some particular strategies that really address uncontrolled hypertension in patients with obesity?
Well, can we go to, is the next slide? Don't remember. Okay. Well, we'll get to this. This is part of it. So the first thing is that just as you would any other patient with the increase in blood pressure, you're going to want to make sure that patients are able to self-monitor their blood pressures, because it can't just be the blood pressure that's in the clinician's office. If the patient already feels bias in a clinician's office, already feels embarrassed in going to a clinician's office, or nervous for whatever reason, the first thing that's going to happen when you get to the clinician's office is what? Probably going to get weighed, right? And so, maybe that contributes to anxiety and such. So what you're really going to want to do is you're going to want to make sure that folks are well trained on self-monitoring of ambulatory blood pressure. And one of the things that's going to be especially important for the patients with the obesity is make sure you got the right size cuff, right? Making sure you got the right size cuff and stuff. Recognize that obesity is a cardiovascular disease risk factor. So getting that blood pressure under control is going to be part of the treatment plan, in addition to, because again, we talked about how it's not just the weight of the patient, it's the health of the patient, okay? And then, the same sort of general recommendations you would make for most folks nowadays, I think, is that maybe want to start, particularly if they have moderate increases in blood pressure, start on two first-line agents as opposed to just maxing out the dose of one and then go to another. I think more and more people are initiating therapy with these kind of combination agents. Is that your sense about where
certainly something that we encourage with our blood pressure work and recommended by current guidelines? Most of our patients with uncontrolled hypertension won't become under control with a single class of medication. And the sooner we get blood pressure under control, the better for our patients. So really starting with 2 classes is really a good way to go in most of our patients. Totally agree. I like your next slide too, because I think you touch a little bit on the importance of measuring blood pressure accurately, how to approach that. That's something we work on a lot here as well. Any comments you want to make there?
No, I think these are just standard. The big one, that's the reason I underline it and bold it and everything. Just be sure that it's got the proper cuff size, that the clinician's office, wherever it's being measured, that it's got that kept in mind. Look, obesity is an epidemic, so it's not like you don't need it. Like, I don't know too many practices couldn't benefit from having the appropriate size cuffs and such. And in some ways, measuring blood pressure inaccurately is worse than getting no blood pressure at all, right? I mean, your data is only helpful in the fact that it's accurate. So again, just focusing in on that you have the right type of equipment, right size cuff, that's key.
Making sure you have those extra large cuffs. So I know we want to get to some audience questions in a moment, and I'll remind everyone who's tuning in, if you do have questions, please go ahead and add them to the chat if you haven't already. Just a couple quick additional points before we get to those audience questions. I like this question as a PCP. When do I need an obesity medicine specialist for one of my patients? What are your recommendations there?
Well, yeah, and for clarity, that there are people like me who are diplomats of obesity medicine. And there's a specific set of criteria, and we have to take an exam and, all those types of things. And then I think this program is being co-sponsored with the Obesity Medicine Association. So again, clinicians, physicians, nurse practitioners, physician assistants and such, we're, just all multidisciplinary folks all in one organization. And it's an organization of people who are focused on treating of the obesity. So if you are a clinician who has all of these facilities available as that's just as available as a person that's an obesity medicine specialist, then you're probably going to be fine. But it's just like with lipids or something, so, I mean, anybody can take somebody with mild dyslipidemia and put them on a statin. You don't need to send everybody to a lipid specialist, right? But if you have a especially challenging patient and you've tried maybe, some of the newer drugs or whatever, and you're just not getting anywhere, the good news is there are people available out there that do have a, specialized interest and perhaps are diplomats, have this certification, that might be another option for the patients that can't be managed in a primary care setting.
Yeah, and if we go to the next slide, I'll just make my quick comment that I'm personally glad that we're seeing more and more physicians going down this path of becoming board certified in obesity medicine. I really think we do need to have access to that level of expertise for some of our patients. If we go to the next slide, I think just kind of wrapping up our sort of presentation section, any kind of final considerations you want to lay out? I know you have a couple of slides here with some resources and things you wanted to highlight.
How did that get there? Look, so it wasn't that long ago that I did a review on cardiovascular disease prevention, published this, things to know about cardiovascular disease prevention. And one of the sections obviously was on hypertension. And one of the resources that I found, just practical resource that was it's just invaluable in clinical practice, is from the AMA. And I told you this before. Yeah,
this is not a plant. You came across this on your own.
And especially, I mean, all these things are important, I'm sure, but the one especially is the one on the far right down there, where there's this U.S. blood pressure validated device listing, where somebody has vetted these blood pressure devices and such, and gives, I mean, I want to be careful how I characterize it, but give guidance to clinicians and patients as to which devices may be good options. So before I get myself in trouble, Kate, why don't you tell?
We're going to come back to a slide on that. You characterized it correctly. What else do you want to share?
Okay, well then the last thing is, look, I think where we're headed in medicine is full circle. There was a time when I first started training where if a person didn't have diabetes, hypertension, and dyslipidemia, and they put on 20 pounds, and now they got all three, as a primary care clinician, we would go, why don't we engage in healthful nutrition and physical activity, and let's see if we can help all of these things, treat the entire patient, right? Let's work on that first before putting somebody on 12 different medications, right? That's the way we used to do things. Then I think we kind of got away from that. And I think now with the GLP-1 receptor agonists, if you do have patients with, again, mild to moderate diabetes, hypertension, dyslipidemia and such, particularly if the dyslipidemia is high triglycerides, and you believe these are related to the increase in body fat, if a person does not have acute disease, I'm seeing more and more gravitation towards saying, why don't, in addition to the nutrition, physical activity, what about the use of one of these GLP-1 receptor agonists to see what that does with regard to the blood sugar, with regard to the blood pressure, with regard to the triglycerides and such? How much improvement can we get in a patient's health by addressing the underlying cause, which I think most primary care clinicians, if they had their druthers, that's what they would rather be focused upon. So again, going kind of full circle.
I agree. I think that's a great kind of summary point here. So We are getting some questions. We also had questions that were submitted from audience members when they registered. I'm going to start with one of those. Social determinants of health. How do you see that fitting into this discussion?
Well, obviously, we talked about before when one of the challenges of populations that are underserved from a socio and economic standpoints and such is there are limitations with regard to food choices. I mean, you've heard the term, food deserts and these types of things, and that's a real problem, particularly now where it seems like in the places where you would need the most healthful foods the most, people are abandoning those areas of the United States, right? And so what's left is, again, the most efficient, the most ultra-processed foods and such. That's a problem. Mm-hmm. Then there's also, matters of race that look, all of us have stresses in our lives, and I get that, okay? But imagine for people, so obviously I'm a person who's white, right? Caucasian, right? I can't even imagine, some of the times I get under stress and I'm quite certain my blood pressure goes up. I can't even imagine going through the kinds of stresses that sometimes I go under and then have additional stresses just because of my race, right? Adding that on, and then adding on further is this understanding, this, the systemic, I guess just systemic racism that goes on, wherein, there are these biases and issues that are taking place that even maybe the person doesn't even know it. So there's blatant acts of racism that people know about, certainty. Then there's other acts of racism that a person of color may not even know. So it's the certainty uncertainty principle that adds to the stress that a person that's that is not a person of color. You're adding all of those on. And I've looked at the literature, and it is actually variable, the degree by which systemic racism contributes to an increase in blood pressure. But some studies do show that. My best conclusion would be, for individuals, I think it's very much a major deal. And secondly, if it were me, okay, if it was me, I think there are just so many things that I see, some of my colleagues have to go through. My blood pressure would be going through the roof. So, it's just my personal, experience and such. So whether it be social and economic, or whether it be race or these types of things, I think all of those for the individual particularly can certainly contribute to worsening blood pressure.
Yeah, I think we could have a very extensive discussion about equity in this whole conversation that I think would be very, very valuable. I'm going to ask you for a 15-second response to a question before we have a couple things we'll run through to close out. Sleep apnea, we kind of briefly touched on. Anything else worth mentioning quickly in terms of how sleep apnea fits into this picture?
Obesity is a contributor to sleep apnea. Sleep apnea is a contributor to hypertension.
Perfect. Love it. That was a very good short answer. Thank you. Harold, Dr. Bays, thank you so much for joining us today. I know I have learned a lot today. I hope our attendees have as well. Before we wrap, I want to share just a few resources with everyone. First of all, this session is a CME activity. It is eligible for 1 AMA PRA Category 1 credit. We're dropping the CME link in the chat, but it will also be sent afterwards as a follow-up. I also want to share the actual practice statement that we were talking about today that was written, titled Obesity and Hypertension, Obesity Medicine Association Clinical Practice Statement from 2023. Next, you touched on a couple of these things. I'm sharing that AMA's Improving Health Outcomes team offers a whole lot of tools and resources for physicians and care teams and patients on improving hypertension control. We offer our AMA MAP Hypertension Quality Improvement Program, a free evidence-based quality improvement program that provides a clear path to significant and sustained improvements in blood pressure control. There's a QR code for that program here. And then you touched on this as well. If we go to the next slide, we have a QR code for the validated device listing. This is where you can find devices that have been independently assessed and confirmed to be validated for clinical accuracy. So all of these links will provide in the chat. We're also sending these resources out after the presentation. And I really, again, I want to thank you for being with us. I hope everyone just enjoyed the discussion, and I hope you all have a wonderful day.
Thank you.